Dr. Nishikant Bose is, I think you already introduced. Yeah. So we'll be speaking on vitrectomy for retinal arterial occlusions, and we all know he is, I think, a master of treating this artery occlusions with surgery, and he has got many awards for, I think, for his videos which he has presented on how this the arteries open up after surgery. Over to you, Nish.
Okay, thank you very much. Thanks to AIOC for giving me a chance to present. Now, we know that this is the usual flow chart that we have in case of a CRAO. We usually try paracentesis, IOP reductions, ocular massage, which can give a resolution, but now what if you have a non-resolution? And if you really don't have a resolution of the CRAO, you really don't have any other options, and you run out of the options, and that's where maybe vitrectomy would come in, and that's what I thought, and that's why we started thinking of other options. Now, can medical thrombolysis work? Now, this was also tried in the Eagle study, but it doesn't work because the common cause of embolus is not a thrombus most of the times in CRO. It is either a cholesterol plaque in 74% of the cases and fibrin in 15% of the cases, or a calcific material. So if these are the three materials that are really going to cause the occlusion, you know that TPA is not really going to work, and that's why we really need a surgical option. Now, what are the options for vitrectomy, and why vitrectomy is so good is because it gives us an option of inducing hypertony, which you can do with paracentesis, and this option of inducing hypertony can last up to 24 to 48 hours if you do a good low hypertony vitrectomy. We can directly massage the central retinal artery occlusion, and this can help in dislodging the embolus in many cases. Now, this is one photograph in which you can see the CRAO on the right side, and you can see the dislodged embolus post-operatively after the perfusion has been established. So this is a typical case of a CRAO where you can see we have induced hypertony, so you can see the choroidals coming in, and after the choroidals coming in, you start seeing the pulsations of the central retinal artery, and then when you start dissecting the disc, you get this thrombus getting dislodged. Now look at the particular thing. It is an embolus and not a thrombus, and that is what I wanted to highlight. You can see it is totally white in color, and that's why I always say that your TPA is not going to work in certain these cases because it is not a thrombus, but it is an embolus which is coming in from different parts. So this is the important part for us to know. Now, this particular case was very well demonstrated by Dr. Somil Seth, and you can see this patient has one-eyed and he had perception of light vision, and after vitrectomy he got back 6 by 36, and you can imagine how valuable that is for a one-eyed person. So we had evaluated about 24 eyes who had come to us as early as before 24 hours, and we could have a good visual improvement of more than 6 by 60 in 8 eyes, and moderate visual improvement in about 7 eyes, and minimal improvement in just 4 eyes. Now in 5 eyes there was no visual improvement at all, and that can be if the occlusion is very deep and the duration of CRO is very long, and if it is associated with certain conditions like severe hypertension and vasospasm, etc., then this surgery is not going to work. Now, what is we can do further to see what more we can do? Now, basically, we just need to know where the embolus is, and visualization of the deep embolus becomes a big problem for us. Now, this is a superficial embolus. On a B scan, we can easily see that, and we know that surgery will work. But many a times we are unfortunate, we don't get such amount of visualization commonly. So what is the problem for the surgery? The first important problem is duration. We have to find out which is an acceptable window, and I know that if it is within 24 hours, you do get some amount of improvement. And if it's within 6 hours, that's the best improvement. I had an anesthetist who we operated within 6 hours, and she got back 6 by 9 vision. So that's how important it is. But yeah, time window is the most important, because the survival of the retinal cells is totally dependent upon the time for which the blood flow has got suspended. There is some amount of residual blood flow which does help them survive for some time, but we don't have a method of quantifying how much is the blood flow accurately, so we really don't know how much is the survival thing. Second is we really don't have a very deep visualization of the vessel, so we really don't know where the occlusion is. Whether the occlusion is at the lamina curvosa or whether the occlusion is at the site where the CRA has penetrated into the dura mater to enter the optic disc. And therefore, a deep imaging platform will be very important for us in the future for us to know how to manage CRAO. And like Dr. Nada said, now we can also try to do endovascular surgery where it was tried by the Japanese co-workers, in which they actually went in, and this is a case of CRAO where they have taken a very thin 41 gauge cannula and actually 47 gauge, sorry, and actually cannulated the CRAO and pierced it, and they have injected TPA for 3 minutes. Now, the workers themselves, I had a word with them, and they are not sure whether the TPA has worked or it was just the flow which was maintained for 3 minutes helped in dislodging the thrombus, and they have done it only in one or two cases, so they are also not sure whether it's going to work in all the cases. And you can see that at the end of this, the perfusion is restored, and you can see the patient is done well, and there is no vitreous hemorrhage. Now, many a time people have asked me that if you see the thrombus on the central retinal artery, can you just nick the CRA and remove it? I have done that in a couple of cases, and believe me, the hemorrhage is not too bad. It settles down within 10 minutes, and next day you really don't get a massive vitreous hemorrhage that we would expect. So to summarize this surgical procedure is challenging, and a lot of challenges are there. Of course, you would need a robotic technology in the future with an armrest if you're going to have such a fine needle piercing exactly into the central retinal artery. So the futures of central retinal artery surgery are definitely there. Till the time we can do whatever is in our hand, like trying to massage the central retinal artery, try to have a low hypotonic vitrectomy and dislodge the embolus the way I could have done in few of my cases. Thank you. Thank you very much.